This is Willie Kemp. This lecture is Anemia, General Features and Laboratory Testing, and this is part 1 of 7 parts of lecture on anemia. There are my websites where me and Dr. Hughes have questions. Still got to work on ours a little bit. And then on Twitter, haven't been active for a while, but I'm going to start again. So just so you know, I'm a forensic pathologist, but I have a very strong interest in general and organ pathology, not just trauma, and I really enjoy teaching medical students. So these are the disclaimers. There's 3 disclaimers. Please read these before viewing the lecture. And if you disagree with any of them, please do not view the lecture. Third disclaimer, and then in case you want to understand my teaching style, I did a little introduction lecture too. If you want to see that, if you're not familiar with the way I teach and stuff like that, please view that if you're interested. Here are the references that I use for these lectures. Just say at the beginning one, but Make It Stick has a great stuff on teaching. There's a technique I use in here that they use. Robbins will be my main guide. The other ones there, that Clinician's Guide to Laboratory Medicine, fantastic book on how to guide yourself during thoughts as you're interpreting labs, values and stuff like that, what to order, things like that. And Dr. Stern's book, fantastic book on how to formulate a differential diagnosis, key points, and everything like that. And I have no financial interest in any of those. I just wish they had been available when I was a medical student. So at my start of my lectures, I like to put a question, and then they told me that, and I use this at UND. I learned it there. They say it kind of guides you to better retention of the lecture. And what we'll do is we'll talk about it at the end. So if you don't know the answer, that's fine. The lecture should give it to you, but it helps you guide you through the lecture. Okay, so the basics of anemia. Basically, it's loss of red blood cells. It's going to lead to a reduced oxygen carrying capacity in the blood because of that, because obviously our hemoglobin is what the oxygen is bound to and what carries the blood from the lungs to our cells. People with anemia can be asymptomatic, fairly asymptomatic, but they can also get dyspnea exertion. Anything where they're going to need more oxygen, they're just not able to provide it. Lack of oxygen can lead to fatigue. And then it says with underlying coronary artery disease, they're going to be more sensitive to lack of oxygen. They can get exertional chest pain. The signs of it, you can see pallor. Remember, red blood cells are what gives our skin, our organs, its color. Other than melanocytes and that, but it does give them their color. Oftentimes at autopsy on a person who died traumatically and has lost a lot of blood, the kidneys will not be their usual dark red, they'll be pale tan. And it's because of loss of blood, and that's what gives the organs their color. So you can see pallor. It says specifically at the conjunctival rim and also in the palmar crease. But one important point was that it's never a standalone diagnosis, i.e. if a person's anemic, you got to determine why. You don't just diagnose anemia and stop. You have to determine why they're anemic. And then the other thing is the physical exam has a very low sensitivity and specificity, and that's why laboratory testing is very important. So as I was going through preparing for this lecture, I just thought I'd throw this in, just kind of something to think about as you go. So when you get anemia, what are you going to do? It's going to act on the kidney to secrete erythropoietin. Erythropoietin is going to act on the bone marrow and cause erythroid hyperplasia. You're going to cause a increase the number of precursor cells to red blood cells, so you can increase the number of red blood cells. And it will act on the liver and spleen, and you can get extramedullary hematopoiesis, which will contribute to some degree of hepatosplenomegaly. Now, obviously, this depends upon the type of the anemia. And if the anemia is actually due to decreased erythropoietin production, you wouldn't have this. But I just thought it was kind of a neat little simple way of looking at some of the changes that you'll see and why you'll see them. Okay, so we're going to talk about laboratory testing. We'll also talk about laboratory testing as we go through each of the different disease processes that cause anemia, but just here at the beginning, give some basic background. So the red blood cell indices are very important. MCV is used oftentimes as the initial step in deciding what type of anemia you're dealing with MCV of less than 80 being called microcystic and greater than 100 called macrocytic, not cystic. Mean cell hemoglobin, or MCH, is the average amount of hemoglobin per red blood cell. Mean cell hemoglobin concentration is the average concentration of hemoglobin in a certain volume of red blood cells. And I was told, and I have read this here, that it used to be important, but now it's actually so regimented that it's actually more of a QA/QC type thing for the instrument, and should be pretty much normal in everybody when it comes out, something along those lines. And then red cell distribution width is the measure of the variation of red blood cell size, and this can be important. Some of them, for example, iron deficiency anemia is known for having a high RDW. So sometimes RDW can help in your differential diagnosis. So since I just mentioned it, we'll talk about all these diseases. At the beginning of this lecture and the second lecture, I put in a lot of flow charts and stuff like that. You can obviously go through the lectures if you want and go back, or however you want, but I think the flow charts are kind of useful when you think about things. So like I just said, MCV is a really great way to divide out some types of anemia. So if it's less than 80, 80 to 100, or greater than 100, there's a differential diagnosis there. So less than 80 is usually iron deficiency anemia, anemia of chronic disease, thalassemia, and sideroblastic. Now, some places I have read hereditary spherocytosis, which makes sense since you have smaller cells with hereditary spherocytosis, but some do not lump it in microcytic, they lump it in normocytic. And with these, you're going to look at things like serum iron, total iron binding capacity, transferrin, serum iron, total iron binding capacity, TIBC, transferrin, and transferrin saturation. Sorry about that. But we'll talk about that with iron deficiency anemia. With the MCV of greater than 100, that's a macrocytic. So things like B12 folate deficiency, which are also causing more of a megaloblastic, where it gets upwards of greater than 125. Reticulocytosis itself can do it. Reticulocytes are actually slightly immature red blood cells, and so they'll be a little bit bigger than normal. And liver disease, alcohol use, hypothyroidism can do it. So with these, because the main cause be B12 and folate, you'd want to check those. And then, as I just said, since liver disease and thyroid function can do it, you'd also test liver and thyroid. So testing to diagnose cause of anemia. These are just some. Reticulocyte count is one. This is one of the first ones we'll talk about, because if the reticulocyte count is elevated, it means that the body's reacting to the anemia and it's trying to produce more red blood cells. And if it's lower, it means it's not reacting to it. So it can help in the distinguishing between is it due to increased destruction or decreased production. Serum iron indices, I just mentioned these before, but iron binding capacity, the total iron binding capacity, TIBC, transferrin saturation, and ferritin. And I bold-faced ferritin because of the ones, that's probably the most important one. And like I said, we'll go through the chart the way you separate out with iron deficiency, anemia of chronic disease, and sideroblastic. Unconjugated bilirubin, because when hemoglobin breaks down, you get unconjugated bilirubin. Haptoglobin is a sign of both extra and intravascular hemolysis. Lactate dehydrogenase, kind of break down the red blood cells. Folate and B12 we mentioned. Hemoglobin electrophoresis, because some forms of anemia are due to abnormalities of hemoglobin or just the lack of production of the hemoglobin. Coombs test, I'll show you a diagram of this and how it works. Basically, it's looking for antibodies against red blood cells. And others, and these are very important, are RDW, as we mentioned, red cell distribution width, variation size of the red blood cells, and peripheral smear, vitally important. So they're at the bottom, but that doesn't mean they're not important, because they are. Because peripheral smear, there's a lot of different morphologies that can help you identify the underlying disease process. So since I've mentioned it, we'll talk about reticulocytes here. So the arrows show some of the reticulocytes. Everywhere you see blue, you see a little bit of basophilia, and they'll be slightly larger than normal. So with something like this, you could work your way towards somewhat macrocytic, but you never have a megaloblastic. So when we're talking about reticulocytes, when the reticulocyte is given, it's given as a reticulocyte count, but you have to correct it. And then in Dr. Stern's book and also in the laboratory medicine guide, they say you actually have to develop the reticulocyte production index. So there's the calculation that's used. The correction factor at the bottom kind of varies between the books that I read, but the idea is you got to get an actual objective measurement. Sometimes the first one you get is kind of more subjective and not may actually represent it. But if it's elevated, that tells you that the body's responding to the anemia. So acute blood loss would be one, and that'd be one where you're losing red blood cells, so it makes more. Hemolytic anemia also, if the red blood cells are breaking down, then the body will be producing more. Also, it says if you have a response to therapy for anemia. So if you have somebody who has iron deficiency anemia and you start giving them iron, they're going to start making more red blood cells. So the reticulocyte count will go up, and they'll have a greater than 2 RPI. If it's less than 2, it's all the other ones. The first thing it says to go for is if that has MCV. And then if you're looking at breakdown, you want to do things like LDH, bilirubin, urine hemosiderin, haptoglobin, plasma urine hemoglobin. And we'll go through these. This is just kind of an introduction to it. We'll go through these as we go. Okay, so I use slides to tell me where I'm at in my lecture, so about halfway through. So these are going to be a little bit longer than I thought they would be, but sorry about that. But still try and keep them relatively short. So this is, I always forget if it's bison or buffalo, which is the correct one. This is at the Billings Zoo. Billings Zoo was in one listing was ranked one of the top 10 in the nation. It's kind of cool. It's kind of a neat little zoo. Okay, so this to me is very high yield for things like national exams, tests, stuff like that, because there's morphologies of the red blood cells that are specifically linked to certain types of diseases. So spherocytes you see in hereditary spherocytosis. What there'll be is little contracted small red blood cells with no central pallor. Autoimmune hemolytic anemia can also do it because it kind of picks away at the outer surface and makes the shell kind of shrink. Schistiocytes are fragmented. These are found in microangiopathic hemolytic anemia. There's kind of shearing of the red blood cells. Target cells, they look like a little target. They have a little red dot in the center. Around that, they have a rim. These can be found in a range of things: thalassemias, liver disease, post-splenectomy. Teardrop cells or dacrocytes. These are found in myelofibrosis or marrow infiltration. They look just like a teardrop. And I'm going to show you some of these as well as images. I just want to list them here. Bite cells in glucose 6-phosphate dehydrogenase deficiency. Basically, it's like they took a bite out of the cell. You can also see Heinz bodies in that, but that requires a special stain. Burr cells are echinocytes and spur cells are acanthocytes. And it took me a long time to tell these apart, but Burr cells are just evenly spaced short projections, and spur cells are unevenly spaced long projections. Burr cells you commonly see, and they commonly see because they're artifact. Sickle cells in sickle cell disease, and then elliptocytes in hereditary elliptocytosis. So here's some of them. These are to the left are Burr cells or echinocytes. So remember, Burr cells are regularly spaced short projections, and spur cells are irregularly spaced long projections. And the elliptocytes in hereditary elliptocytosis. And I put down there the difference between Burr cells, the echinocytes, and spur cells, acanthocytes. Target cells, they look basically just like a target. You can see these in liver disease, thalassemias, other ones. It's kind of interesting because with red blood cell smears, in my opinion, you can look at any one smear sometimes and see a range of morphology. So it's great for teaching because you can see on any one smear. But those are the ones that's commonly associated with. So you probably see a predominance of them. If you see one target cell on a whole smear, that doesn't mean anything. But if you see a regular abundance of them, that means something else. Teardrop cells. With dacrocytes, you can see right there, it kind of looks like a teardrop. So my idea is it's kind of the red blood cell is trying to pull itself out of the fibrosis and kind of stretches itself out. And then we talked about RDW, the red blood cell distribution width. The common one is iron deficiency anemia there. You have microcytosis and high RDW, that's iron deficiency. You can see there with anemia of chronic inflammation or anemia of chronic disease, both terms are used. It actually falls in three of those four categories. And even with this, you can see with early iron deficiency, you can have normal cytosis, normal size cells. So it kind of shows you that, oftentimes, remember with medicine, it's a spectrum of changes. So here's the question. So pause the recording, look at it, answer it, and then the next thing we'll go on to and describe it. So pathology examining in blood smear as hematopathology rotation identifies the red blood cell at the arrow. If the morphologic change is represented in the smear of the following, what is most likely the patient's underlying medical condition? So that's a teardrop cell, a dacrocyte, so that'd be myelofibrosis, like it's pulling itself out from the myelofibrosis. And so my second to last slide is reflection. So in that book, Make It Stick, they talk about this technique. And what it is you sit there and you read something or watch something, and then you stop and you think and you go, what did I just learn? What did I just read? And it said in there, they had a specific example of a medical student who used this technique and went from bottom of their class to top of their class using only this technique. So I try and encourage it by doing this. I'm not going to list 5 things for you because you get in the habit of just going on the next slide, but stop, think of what are 5 things I learned from this lecture, 2 things I learned from this lecture, and it helps you remember the material. And then my last slide is at the Billings Zoo. It's kind of neat. It's kind of a zoo arboretum. There's a lot of walking, a lot of plant life, a lot of animals that are common in the area and stuff like that. And it's actually really neat, neat little zoo. So that's it. I hope this information has helped you understand anemia better. And there'll be 6 more parts, 7 total. Thank you.